All right. Once again, welcome to our Mames Rehab Special Committee Networking session. My name is Rose Schaffhauser. I'm the Executive Director for Mames. For those of you who do not know me, we're going to do a few introductions because we do have quite a few folks on our phone. So I'm going to open it up and have our Rehab Chairperson, Nancy Frosley, introduce herself.
Good morning, everybody. My name is Nancy Frosley. I am with New Motion, and I am the chair of the Mames Rehab Committee.
Thank you, Nancy. And then we also have Greg Newth. He's our vice chair. So Greg, if you'd like to introduce yourself.
Good morning, my name is Greg Newth. Volunteered for the vice chair, so hopefully I can be a part of this and look forward to moving forward with everything.
Wonderful, thank you. And I'd also like to introduce Greg Packer. He is on mute, it looks like, but Greg Packer was, as Peter mentioned, he is the one that reached out on behalf of the committee to Peter to invite him to this session. And I just found out this morning they are actually, US Rehab is sponsoring Peter. So what we're going to do and how this session is going to work, we're going to hear from Peter and talk about some of the work that the ITEM Coalition has done around this product category. And then we do expect to have, after Peter gets done, talk more about the equipment and what's happening on a national payer level. And then basically open it up to the group for some of your questions. We thank some of you for the questions that you sent in beforehand. So without further ado, Peter, I'm going to turn it over to you if you'd like to introduce yourself to the group and get us kicked off.
Sure, I'd be happy to. Can you hear me okay?
Yes, we can.
Okay. So I'm Peter Thomas, and I'm an attorney in Washington, D.C., law firm called Powers, Piles, Sutter, and Verville. We go by Powers. We do healthcare, education, and the law of tribal nations. We have had a strong legislative practice since the mid-'70s, early '80s, and I focus on rehabilitation and disability from the healthcare aspects of those two kind of issues, medical rehabilitation, of course. So one of the things that I work on is access to technologies and devices. And we put together a coalition called the Independence Through Enhancement of Medicare and Medicaid Coalition back in 2003. The short name for that is the ITEM Coalition. You may have heard of it. I'm sure some of you have, because some of you have been working very closely with the ITEM Coalition over the last few years, in particular the past year on this issue of standing feature or standing systems and seat elevation coverage under the Medicare program. The ITEM Coalition has been working on this particular issue for some time, since about 2014, when we drafted a paper and went to meet with, back then, Lawrence Wilson, some of you may know that name, at CMS, who's now since retired. He's from the government, but he's with a consulting firm. We met with him, we talked with him about the notion of covering seat elevation and didn't get very far. We tried to advance the ball, it didn't really happen. We got back kind of a letter that kind of blew us off. We regrouped, we put together had an interest in putting together not only a coverage request for seat elevation, but also for standing systems that were becoming more and more prevalent. And we just couldn't understand why tilt and recline was considered primarily medical in nature and therefore a covered DME benefit under the Medicare program, but seat elevation and standing systems were not. We just didn't see the difference between the technologies and why would one be primarily medical in nature and the other would not be. So we ultimately, about 2.5 years ago, drafted, it's now 3 years, we did some extensive research. We drafted a very comprehensive legal and clinical argument for coverage of these two systems. And we sent the letter to Seema Verma, who is the current administrator of CMS. Today is her last day. And ultimately asked her for coverage of these two systems. That was August 7th of 2018. And since that letter, we have met up and down the chain of command at CMS and HHS with a whole wide variety of people who would have a responsibility for making this determination. Everyone from the front line, kind of Joel Kaiser and the folks in the chronic care policy group, all the way up through Liz Richter, who directed the Center for Medicare at the time, up to Dimitrios Kazoukas, who's the principal deputy at CMS, and then some very senior folks at the Department of Health and Human Services in the Secretary's office as well. And we went, we met with the chief medical officer. We went in and did demonstrations. We had 18 people over to CMS in the fall of 2019 to demonstrate seat elevation and standing systems and lay out our arguments, and met with the chief medical officer at that point, who also was the director of the Center for Clinical Standards and Quality, which is the sub-agency within CMS that makes the decisions about coverage. So we didn't get a no. We weren't told, no, you can't get coverage of this, and that was positive. But we also didn't see much progress being made with this kind of approach. They don't have a very clear, or at least they didn't then, have a very clear way to approach CMS and ask for a benefit category determination and subsequent coverage. Serendipity prevailed, and in February of 2020, I happened to see at a function, after hours function, Dimitrios Kazoukas, who again is the principal deputy. Today is his last day as well. And he said to me, listen, I know you ought to be kind of ticked off at me. I know you've been waiting a long time for this decision that you submitted this letter on. And I've been getting some people within CMS and HHS who have been telling me we ought to give this some serious consideration.
Carolyn, you got 2 minutes because I'm going to get out of here after this. So I went through my list. I'm just curious on what yours looks like. And make sure, because I'm going to be using this. This one's 5 times easier for me. So like here, Jason, anything that's in yellow, I'd send him an email.
What do we do?
Update return. Or send him the list. I color coded these. I just take the names, copy them, each one of them.
Catkins.
Hey, Karen, Karen, we can hear you.
Need to know stuff. Oh, sorry. My bad. Sorry, I'm trying to multitask. I apologize.
No problem. Okay, so he basically said, why don't we get on the phone and talk through what the next step might be? So we did. We called my colleague Joe Nara, who works with the Item Coalition, and I got on the phone with Dimitrios in February of 2020. And he said to us a few things. First off, it was a half-hour phone call, about 25 minutes of which he was laying out all the reasons why CMS didn't have the bandwidth to go forward with this issue, and they had a lot on their plate before the term ended. This was before COVID even struck. So he was complaining about the ability of his own staff to get everything that they needed to get done, plus this, and was discouraging to say the least. In the last 5 minutes, the conversation changed. He basically said, what I'd love to do is to get this accomplished without rulemaking. So what he was signaling was he was kind of with us on coverage, but he didn't want to have to go through the whole notice of public notice and comment rulemaking process, which is time consuming. It takes a lot of staff, and didn't want to have to do that. And he said, if you can figure out a way to get through the agency without going through public notice and comment, and if you can show how seat elevation and standing systems differ and differentiate them from other kinds of benefits so that we don't have a flood of new applications for coverage in this field, then you'd have something there. So we put together a set of subgroups. Julie Periano was on the clinical subgroup and helped immensely. Greg Packer was a big supporter. Nancy, thank you to New Motion for all of your support for this initiative. There were quite a few folks in the mobility device space that came forward and I either put up contributions of financial contributions or in-kind contributions to try to get this off the ground. We created 4 subgroups. We analyzed the legal issues. We came up with a strategy to submit a national coverage determination request for coverage of these 2 systems. And then we spent about 3 months drafting a very comprehensive NCD request, which had 2 parts. First, a benefit category determination to determine that both standing feature or standing systems and seat elevation in power wheelchairs, in group 3 power wheelchairs, should be considered primarily medical in nature and therefore are DME benefits. And once that occurs, then the question is, who gets it? Who gets access to it? Who needs it? What's the coverage policy for those 2 systems? And so we put a 64-page national coverage determination request for reconsideration together. We tried to heavily footnote it. We did a lot of research, and the clinicians task force was instrumental in pulling together the clinical evidence and in helping to draft the sections of the NCD that made the case for coverage. We had over 300 footnotes and 120 sources. We put together a red line version of the national coverage determination for mobility assistance equipment and how that would need to change in order to cover these 2 benefits. We even drafted a local coverage determination so that we would lay out exactly who would have access to this and who would not. And we actually also went the extra mile and consulted with and hired Dobson DeVanzo, which is a freestanding independent analyst, health policy, a health economics analyst, to go through and try to forecast what these 2 benefits would cost over a 10-year period. And, he worked with the clinicians to identify the particular types of diagnoses that would be typical of a patient base that would not only use a group 3 power wheelchair, but would also need seat elevation or standing feature or both. And so we put that all together and we submitted that on September the 15th of 2020. And around mid-November, late November, we got the response that the NCD request was deemed complete. That was one step in the process. Once it's complete, then it goes through a process within CMS. We've since met with CMS a few times. I've talked to Demetrios a few times and some other folks at CMS to try to get a better sense of where we are. The NCD request is supported by over 65 national organizations, disability, clinical, healthcare organizations in this space. The American Medical Association passed a resolution and supports coverage of these 2 systems. The National Council on Disability weighed in and sent a 5-page letter to the administrator and the secretary, encouraging them to grant coverage of these benefits. There's just been a tremendous amount of support, congressional support as well. There's been members of Congress who have written supporting a serious examination of coverage of these 2 features. So where do we stand now? We expect in the next week or 2, I shouldn't say that, in the near future, we've got a transition happening. We don't exactly know what the timing is on anything right now, but I'll say in the near future, we are expecting the CMS to put the NCD out for what they call it, opening the NCD. They would open it, which means that they'd publish something in the Federal Register that indicates that they're now looking at an NCD in this area. They seek public comment. They look for any commentary from any experts in the field, and we'll be orchestrating some kind of a response to that, of course, and we'll get the word out as broadly as we can so we can get as much support as possible. Once that happens, they'll then come out with a preliminary decision. They'll publish that. There'll be another opportunity for public comment. Now, this isn't public notice and comment rulemaking the way the Administrative Procedures Act requires. It's a different process, but it's similar. It's not quite as formal. It doesn't take as much time. It doesn't require CMS to do quite as much work to put this out. But that would be the next step. So over the next several months, they'll open the NCD, they'll publish a preliminary decision. We very well may have additional conversations with them to educate them about the issues from our perspective. They'll do their own research. They'll certainly look at our research that we've sent to them. We sent them over 1,000 pages of clinical articles for their review. And they'll come up with a preliminary decision. That'll be subject to public notice and comment as well, and they'll make a final NCD decision. We're hopeful that, look, there'll be signs. If they put out something seeking clinical evidence and seeking clinical backing, that'll be a signal that they're probably going to deem this primarily medical in nature. They're not going to put that signal out there and then decide that it's not primarily medical in nature and therefore it's not a covered benefit. If they decide it's not DME, this thing is done. We won't have an opportunity to get to the point where we determine who gets it or for whom it's appropriate. If in fact we are not successful in getting this NCD approved or partially approved, maybe they cover one of these functions but not the other, we will have to resort to Congress. That's the only other avenue. The courts can't mandate that the Medicare program cover a benefit if Medicare believes that it doesn't qualify under a designated benefit, i.e. durable medical equipment. So we'd have to go to Congress to try to get this included in the Medicare benefit package. I think we'd have some pretty decent support with that. I think the fact that the Dobson-DaVanzo report came up with a figure of $311 million for this benefit over a 10-year period suggests that this is not a budget buster. This is not something that's going to, drain the fisc, and compromise the Medicare trust fund. But it's an added benefit, and whenever you do that, that's a huge lift, and that would be a big congressional request. So we're hopeful that we don't get to that point. We're hopeful that CMS makes the decision to cover these benefits and creates a coverage policy accordingly. I think I'll stop there and see if there's any questions or comments, and then partake and engage in the networking session.
Peter, that's great information and sounds like a lot of work. So congratulations to you and all the folks that have been a part of this whole process. With that, does anybody have any questions for Peter? It sounds like such an arduous process to get this done. And if you, I know I shouldn't ask this, but if you, knowing what you know and going through the entire process, what does your gut tell you based on everything you're doing?
A couple of things. I think we always have it's difficult to get new benefits covered under the Medicare program. And the fact that they have determined 20 years ago, or at least 15 years ago, 2005 is when they actually, the DME Max actually published a policy article, not even a local determination, a policy article that stated that seat elevation and standing systems are not primarily medical in nature and therefore not covered under the Medicare program. They did grant two codes, E2300 and E2301. Those exist for these features, these systems, but that's primarily for use by non-Medicare insurers and Medicaid programs and the VA and the like. And oftentimes, because Medicare doesn't cover these features, these systems, neither does other payers. There's a lot of payers that don't cover them, as you well know. I think personally that those payers that do cover these benefits have made the determination that these help people. There's plenty of good clinical evidence about reduction of falls and improvement of mobility-related activities of daily living and the ability to perform those independently in the home. I mean, I think it's important to note that we're not seeking something that's outside of the traditional lanes of coverage under Medicare. We're seeking a benefit that meets the in-the-home requirement, that complies with the existing NCD for MAE, that improves the ability to perform mobility-related activities of daily living, and has clinical implications. Standing feature alone, even seat elevation, reduction of falls, decubitus ulcers and skin breakdowns. With respect to standing feature, improved circulation and improved motility, a whole range of clinical benefits as a result of these two benefits, these two features. So we're hopeful that they'll see that and that they'll approve it. The fact that they haven't said no in now 2.5 years, I'm feeling pretty good about. When I get on the phone, I think there are people within CMS that want to do this. They feel they can't really justify covering tilt and recline and not covering this either. By the way, there's also an NCD. There is an existing national coverage determination that covers seat elevation systems that are embedded in stationary chairs. So if you've got severe arthritis and you have a problem either sitting down or standing up, you're ambulatory. You don't need a wheelchair, but you have real problems getting up and down from a chair. Medicare pays for a seat elevator that's then installed in a chair, stationary chair, that will help you rise and lower into that chair. That's covered. Now, how can a seat elevator in a piece of standard furniture, not durable medical equipment, how can that be considered primarily medical in nature? And a seat elevator in a wheelchair, in a power wheelchair, is not considered medical in nature. That doesn't make any sense. So I think they're having significant discussions about this. And I think there's people in the agency that feel it's time to do this. Again, I'm cautiously optimistic is what I've said to a lot of folks. I'm cautiously optimistic. I think there's some indications that they're not only taking this very seriously, but that they can see our arguments, and I think they recognize them. So hopefully, fingers crossed. And with the Biden administration, it's tough to tell. Generally, you'd think that a Democratic administration would be more apt to grant new benefits, but stranger things have happened. I've seen Democratic administrations deny coverage of new things, so I wouldn't take that to the bank. There's a certain ambiguity and there's a certain unknown quantity. They don't have a CMS administrator named yet. We don't know who's going to really be in control at CMS. I would say that the career staff, the folks are going to continue to remain at CMS regardless of whether the administration, what administration's there. I think we've got good communications with them, and I think we're in a pretty good place. But again, it's really, it's a little difficult. I couldn't possibly give you a numerical forecast, but I'm cautiously optimistic.
Yeah, no, we always joke with the folks at AA Home Care. We ask Jay to give us percentages and bet and things like that, and he doesn't bite.
Yeah, he's a smart man. I know.
Right?
He's been very helpful.
Well, you all know we just need answers, and we need them now.
Right.
Well, again, that is encouraging, and it's great information, and you're spot on. I never even thought of it when it comes to the seat lifts being covered. Yeah, that doesn't make sense. How about anybody else on the call have any questions or want to discuss anything related to that? You see, you did such a great job.
Well, I actually have some questions for you, because what I don't have is a better sense for those payers that actually are covering it. What are they looking to? What do you got to do in order to get coverage from payers who are apt to cover it if you can demonstrate to them medical need, or do they quarrel with this notion of primarily medical in nature? Do they consider it they can't consider it a non-benefit, or they wouldn't be covering it. So I assume they cover it under the DME benefit.
Yeah.
Any additional on the ground kind of interaction with current payers would help me.
Yeah, absolutely. Jennifer, I believe you're on the line. Jennifer Sylvester. Jennifer, are you on?
Yep, I'm here.
Awesome. Jennifer,
yep, I'm here.
Awesome. In your agenda, everybody received, there is a list. Jennifer is with AccuServe. So Jennifer, I'll have you introduce yourself. But there, she provides some information about this particular question, Peter. So Jennifer, I'll turn it over to you.
Yep. So again, my name is Jennifer Sylvester, and I am part of AccuServe, and we are a billing and collection service located here in Akron, Ohio. I'm a little new to the group, so when we were planning on the call and putting the agenda together, just since we're not a DME provider, but we're a billing service, you know, how can we help? And is there any data mining that we might be able to do with some of the payers that we work with, and to share that information, you know, with the group, and then, you know, willing to take it a step farther, you know, based on everyone's feedback. So, you know, although, you know, company names and contracts and things like that are confidential, I did just a very generic data pool just to see if there's any activity from the providers that we're working with on payments for the E2300. And if this type of data is helpful, you know, we're happy to deep dive a little bit more, look further into the companies that we are seeing some payment activity, and do some further data analysis to show, you know, what is it that these plans are looking for. You know, are these items typically covered, you know, or, you know, was it just something that was done out of special consideration? But we are seeing some activity for, looks like Georgia Medicaid there, and then some of the Blue Cross Blue Shield plan. Now, the naming conventions, unfortunately, we pull those out of the provider's software. So, unfortunately, not everyone lists their payers in the same fashion. So, some listed Blue Cross Blue Shield of California, some BCBS, things like that. So, I'm sorry that there's not a ton of consistency here on how this actually looks on paper, but we can certainly dig deeper. So, Peter, we want to take this, you know, a step further, and I'm really interested to hear from the group if this is something that's, you know, beneficial, and if the group would like some more feedback on some of the payers that we're seeing some activity on.
Well, I'll certainly chime in and say any information that you could provide would be really, really helpful. But I'd like to try to make sure that we keep this confidential as best we can, because I don't know what you're going to find. And if it's not helpful, I don't want to be sharing unhelpful information.
Sure.
I'm also very interested,
Exactly.
as you know, in E2301. And if you have any payment history on 2301, that would be very, very important as well. And any kind of magnitude, how they're covering this, what benefit are they considering it, DME or something else? I don't think we really need to know pricing information. That's not really all that important. But certainly the benefit category, and if you have any information on the coverage policy or what was required, what was the reasoning to get something covered, that would obviously be critical. And then just numbers, sheer out numbers. How many of these are being denied? How many are being approved? How many do you have in your database? That would be helpful.
Sure. Well, we can run some data mining for the E2301 again, and we can, you know, do a few sample audits on some of the ones that we've seen some positive activity on, and then, you know, report back to the group on, you know, what our findings are and, you know, what were the consistencies between the charts. A lot of the denials that we see, you know, sometimes it's purposely billed for a denial, so it could go on to another payer.
Right.
And then, you know, we have, of course, denials where things are just statutorily not covered, but there might be a, you know, at the customer's request, we're just billing it to get the denial before someone chooses to pay privately. But we can filter out the denials that are true medical necessity denials, where it is a covered benefit, but it was just denied through the PA process versus those that are just, you know, non-covered on the fee schedule. But I wanted to make sure that this is something that would be beneficial to the group, you know, before we spend a ton of time on it. And, you know, it's just for the, you know, obviously the clients that we serve, but we do have several, you know, across the states. And then through OAMES, through our regular state association here in Ohio, we've been working on some data mining projects to track denials for some of the Medicaid HMO plans. So there might be an opportunity too to, you know, share some payment information or denial information from those on the call, obviously taking out the PHI so that we can use our software to do some data mining and report that back to the group.
I love that. I don't know what the rest of the group thinks, but I'd love to get that data once you have it.
Peter, this is Julie. Mames is uniquely positioned in this space. And the reason I say that is because for seat elevation, Minnesota has written coverage policy for it. And Missouri has a policy where it is still, although I would contend not in compliance with information in the Federal Register from February 2nd, 2016, still has an exclusion policy for it. So both opposite ends of the spectrum. Wisconsin has legislated it. So 3 Mames states, you know, are in various arrays of where they look at this and how they've approached it. So we might be able to utilize that as part of the next steps as well.
I love that, Julie. What was that 2016 reg that you mentioned?
I'll send it to you, but it was basically it as of, depending on how states approached changes to policy, whether it had to be legislated or it was rulemaking or whatever, essentially it made it not permissible to have an exclusion list. You were permitted to generate criteria for coverage and consideration, but if you remember, there used to be published exclusion lists. You know, we don't pay for this, sort of no questions asked. And that was counter, from a Medicaid perspective, counter to the ADA and a counter to the Olmstead decision. And so states were required by law to essentially eliminate their exclusion policy, you know, from a 30,000 foot view perspective anyway, and navigate the waters in some other way, shape, or form. Missouri has not done that.
So now I remember this reg that you're talking about. That was at the very end of the Obama administration, as I recall.
It was published February 2nd, 2016.
Okay. So that's great. I thank you for reminding me of that. And if you don't mind sending me a link to it, to save me some time in tracking it down. Now that's a Medicaid issue primarily. It's not going to help us much with Medicare, but it is important precedent, and it's, you know, we may want to consider about, you know, perhaps a state by state approach, or now that you've got the Biden administration that wants to shore up Medicaid, we may want to revisit this with the Biden administration and see if they can send out something to the states to reiterate the fact that they cannot have exclusion lists, and anyone with an exclusion list that hasn't complied with that reg in the last 4 years needs to do so. That's definitely something that I'd like to pursue. So if you don't mind sending me that, that'd be great. And if not, I'll track it down myself.
I'll absolutely send it to you. And I would agree with you, Peter. I think as CMS navigates this in some way, shape, or form, I anticipate a question from them that says, Do other federally funded healthcare programs pay for this? So the ability to say, well, yes, they do, here they are, and here's how they do it. We've already looked at that. We've already analyzed it. And at the time we started this project to today, there are more states that have come on board with written coverage policies around one or both of these systems. So it's moving in the right direction.
Is there a comprehensive list of those states? Does anyone have that?
I've got of course I do. Yes, I'll send you that too.
I'd love to see that. That'd be helpful.
Julie, can you send that information to Rose so she can disseminate it amongst the group? Because I know North Dakota has an exclusion list as well.
Is it on the exclusion list, or is it, it gives the impression that it's excluded? Because there's a difference.
Yeah, I'll have to, it's been a while since I've looked at their their manual. I can definitely look.
Okay. But I think I think that this is a good opportunity for us to take a look at what is in writing and then what's implied. Because I know 6 years ago, when this became my soapbox, and in talking with providers and clinicians and consumers, the general sense is nobody covers this. And you're right, when you don't submit it for consideration, there's never even an opportunity for yes to be on the table. And so there's been a lot of assumed coverage policies that aren't actually in writing. When you don't see it on a fee schedule, there's an assumption that it's not covered or reimbursable. That's a smoke and mirrors. I would contend that if you don't submit it, the answer is always no. But if you submit it with valid rationale as to why it is a necessary component for the individual, then it puts the payer on notice to consider it. And so I think that the list that Jennifer provided is terrific, because it starts to demonstrate that if you ask, there's a possibility. But at the end of the day, it's always related to the details in the documentation as to why the person needs the thing. But Peter, we have since we started this project at Quantum, we've got a running list by report from providers who have sent us when a payer has paid for it. And that may be, they submitted 10 and 9 out of 10 were denied, but the 10th one was approved because the documentation in support of it for that particular individual was deemed necessary. And for me, that's enough. It doesn't matter if they've covered it, 9 out of 10 times or 1 out of 10 times. If they've covered it, they've considered it, and it opens the door to further advance this.
That's really helpful, really exciting, and I'll certainly take a close look at that reg and think about a CMS central strategy to figure out whether they can reiterate the effectiveness and the enforcement of that regulation, and perhaps a state-by-state strategy to target those that still have exclusion lists. That would be a nice complement to what we're otherwise doing on this. So thank you for raising those, Julie.
Yeah, great job, Julie. And I do know, as you mentioned, Julie, Wisconsin was one that did legislate it a few years ago. And I know they have started covering. Greg Newth, are you still on the line, I believe?
Yeah, I'm here.
Do you want to talk about what's happening, what you're experiencing in Wisconsin with this technology?
Yeah, they have started covering them. In the scenarios that I've had, it has required, though, going back to the therapist, having the therapist document specifically what ADLs are going to be impacted and how it will benefit this this patient in their activities of daily living in their home. And 2 out of the 3 times that we resubmitted, the item was covered.
What state was that?
Wisconsin.
Thank you.
And I will say, my coworker here recently submitted for a tilt and recline system through Wisconsin State Medicaid. And they actually came back asking if seat elevate wouldn't be a benefit. It wasn't even requested on our part. The reviewer actually asked if it wouldn't be a benefit.
Wow.
There's a win.
There's a change in paradigm, right?
Right. Yeah. So we're reworking that file as well.
When you're working those files, I would also recommend that, and this is one of the things that clinicians, being one, kind of know intuitively, but it's in their head and doesn't oftentimes show up on the on the paper that gets submitted. And that is, you know, there's the positive side of it, but then there's the other side that you've got to look at. Without it, what's the risk? What's the risk for falls and injury and transfers? What's the risk of burns, cuts, bruises, etc., from reaching, carrying, getting something out of, you know, the hot cook thing out of the microwave, you know, those sorts of things. The number of times that they have to reach overhead in order to access the vertical environment. And so there's the plus side, but then there's the, by the way, if you don't cover this, or consider it, here's what could happen, just so you're aware, you know. And when they're put on notice like that, they're even more likely to consider it because it's a small dollar expenditure to mitigate or at least minimize the risk for a very large dollar expenditure if the adverse occurrence happens.
Yep, that's an excellent point. Thank you. And that's a good item to remember to discuss with the therapist. If they're having to redo or during the actual therapy, that's a system that we're going to look at providing.
Has there been any any written peer-reviewed kind of study or anything like that dictates or that would indicate the cost benefit of this? In other words, what happens if you don't cover this and the costs that could arise as a result of falls or you know, skin breakdowns or other kinds of things? Is there any literature? I mean, there's some materials that we cited in the NCD request, and we have some of those. But is there anything that talks about if you don't provide these benefits, these are your risks, these are your cost-based risks? Do you know, Julie?
Right now, it's primarily anecdotal and case by case. There's nothing in terms of peer review, because we dug as deep as we possibly could to see if we could find anything that gave us a one-to-one. And we found a couple of things, especially as it relates to repetitive strain injuries and neck injuries and those sorts of things, from a low seated position versus an elevated position. But it didn't go that next step in terms of cost benefit analysis.
So you could, not to design a study on the fly here on this phone call, but you could take the evidence base that's existing in the field, and you could do a model that forecasts based on incidence and prevalence of some of these conditions in the wheelchair population, how much those things cost to treat, and what's the typical or average cost for treating something that is, you know, can be studied. We've got numbers on how many falls there are, how many, you know, skin breakdowns there are, flap surgeries, that kind of thing. You could do a model, put together a model and write up something that would really try to capture that cost benefit equation. Could you not? I mean, it strikes me that it wouldn't be that difficult.
I think you could cobble the pieces together.
Yeah.
You know, I think, sorry, this is Kelly Musta from Minnesota Reliable Medical, but I know it took a long time to get standing devices, any kind of recognition and approval from commercial plans and Medicaid plans. And I know years ago, Easy Stand did a lot of clinical trials and studies on the benefits of standing. So just a thought but that could be an avenue to go down when you're looking at the power standing feature from like a Medicare standpoint. But I mean, they cover bone density, scoliosis, circulation, things like that, the benefits of standing and the repercussions of not standing every day.
Yeah, that's helpful. What about the VA? Anyone have experience with the VA with these two benefits?
Yeah, Peter, this is Matt Appleton with Invacare. So I'm the field rep. So I'm working with the providers directly and work with the VA directly as well too. So we do see those benefits being covered in the VA, the seat elevator every day. And then the standing is starting to become more prevalent. And I have done some standards with the VA, and they have covered that benefit as well too. And I was just going to give you a little feedback from Iowa, maybe just from the ground level in a general sense, as far as coverage is concerned. What I'm seeing over the last year, our standard is kind of really taken off for me. And what I'm seeing being covered most generally is Blue Cross Blue Shield policies as well as commercial policies. We have not had much luck with Iowa Medicaid to this point. I don't know if they have a specific exclusion written, so that's something we'll have to research a little bit more. But I am starting to see more coverage from the commercial insurers, specifically Blue Cross Blue Shield as well too. But yeah, we do see the coverage with the VA as well. Mm-hmm.
Is that, Matt, is that Iowa coverage of private insurance, is that primarily seat elevation or standing feature or both?
My experience lately has been with the standing system, actually. Seat elevation, I don't know that I would say there's consistent coverage, but I think you see it with the commercial payers sometimes, but not always. Yeah.
Okay, thanks.
So I think that brings us to a really good point to just ask a couple of questions. For those of you that are seeing coverage with different payer sources, are you using any sort of form to get that covered? Is it any sort of standard language that you're using? What tips can you share?
I know the policies here in Minnesota tend to focus on independence and activities of daily living. So from both a seat elevator and a power standing function standpoint, we do have to show that there is a certain level of independence, whether it's accessing cupboards, independently transferring, but some sort of activity of daily living that they're able to complete independently by use of those two features.
They've also covered it in situations where the individual required assistance, say maximum assistance to transfer between unlevel surfaces, but were moving towards, or there was a long-term goal of independence with seat elevation and leveling the transfer surfaces with transfer training. And so in this situation where there may be even an entirely different technique, being able to demonstrate, and this again is the clinical focus of it, but being able to demonstrate that the potential for independence is there, but you have to have the feature and then the training in order to achieve independence. And so, it doesn't just magically appear, and you can't lie and say they're independent because they need the training. And so being able to articulate it that way has also been demonstrated to work as well, relative to independence and transfers.
Great, thank you, Julie. Anyone else have any tips, tricks?
Could I say that I view these benefits, these two systems in particular, as being inevitable for coverage over time. I think eventually these are going to be just as accepted as any other item of durable medical equipment. I don't know if that's wishful thinking or whether that's real, but I think the case for coverage of these two benefits is so strong, and the reasoning that these are not primarily medical in nature is so weak. When they're embedded in a power wheelchair and they assist persons in the home to perform MRADLs, which is the coverage policy of Medicare, it just strikes me that this is inevitable. Is that too strong a statement, or do people feel similarly?
I feel the same. I'm surprised it hasn't become that way already.
Well, amen. I'm with you on that.
Well, and especially when you look at, they pay for anything that's taken care of or taking place of a malformed body function. Well, if you're not able to stand and you're sitting in a chair, why wouldn't you be able to be standing in a chair? And things like that just doesn't make any sense.
Yeah.
Hey, Rose, I apologize. I've been in and out, as you guys could all tell, because of my speaker issue. So have you guys went over Blue Cross Blue Shield of Missouri?
No.
Okay, so I didn't think you have, but Blue Cross Blue Shield of Missouri pays for everything, all the commercial plans. What we have seen all of a sudden is they have new contracting coming in, and I've been speaking with some other companies, and they are, like, we were even getting titanium paid left and right through the commercial policies. And we've got a doctor right now with about a $15,000 custom K5 chair, 13,000 somewhere in there. And for the first time ever, they've cut out the titanium code. I think they're going to start hammering Blue Cross Blue Shield of Missouri. They've got a new guru in. They've even went as far as calling providers, not myself, to ask them for the Medicare rates. I really think they're going to start pushing it towards Medicare and cut out these power standards where we've never had a problem before. I'm on top of it. My rep, who pushes very hard for this stuff, the Missouri rep has lost her position. They've cut it out now. But she behind the scenes will help me. I also, this is kind of off the subject, we can't even get a K5 prior approved through Blue Cross Blue Shield anymore in the state of Missouri through Blue Cross. It's off the PA list, and so are manual tilts. So but before that, all we were giving them was our ATP eval. Sometimes we had a therapist, sometimes we didn't. We would use a letter writer. The doctors would sign off on the letters. They were even approving them with them and our ATP letter combination. The problem that we have ran into, and I've got one right now, is I've got a guy where they've got Blue Cross Blue Shield Federal, and our contract, and many in Kansas City, they've taken away our K108, and they say if it's like custom codes, we have to use the E1399. The problem is Blue Cross Blue Federal may pay for the power standard, but the codes that are K108, they make us bill as E1399. So when I go to Medicare and I'm just billing the K0861, right, with the upgraded the standard, all my miscellaneous codes that go with standards, Blue Cross will deny, but then Blue Cross is coming back and saying, well, your Medicare statement says K0108. I'm like, but you mandate I use E1399. So I'm in the middle of that train wreck, because we have one right now, federal will pay for a standard. So my approval was before the end of the year. So I talked to Julie about this guy a little bit the other day, but how do you bill Medicare? And I called Blue Cross, and they're like, we're not going to take it if it says K0108. I'm like, then you can't stick me with a contract telling me I have to use E1399 when you have primary payers that won't take E1399. So that's kind of became a problem I think we all better be aware of, is some of these commercials are starting to drive that E1399 code, and your primaries aren't going to take it. Medicare just plops it out. So when we're looking at standards, I think that's something I never thought about until I just ran up against it. And I will keep you guys informed on Blue Cross Blue Shield. But that was our process. We just went to the docs. I mean, a lot of times we didn't even have Pete. It was us and the doc working together, and they were still approving them.
Okay. Well, good to know.
I don't think we ever we had one standard denied out of all the ones we've done. And they made a mistake and told me that it was prior approved. I called the family member, told him it was approved 2 hours later, I get a phone call, and I thank God had a reference number saying it was approved, and got the lady's name. 2 hours later, they called back and said we had a mistake. I said, well, it's too bad you're on a recorded line and you gave me approval, and we won the appeal because I was on a recorded line and made him pull it up.
Okay.
So.
Good info, Karen.
There you
How
go.
about it? How about anybody else? Some great discussion here today. We did have a couple of, I think we did have a couple of pre-questions received. One was obviously the general coverage information on Medicare guidelines. And obviously we talked specifically about that and where we're at on that. But one of the other things, if there's any folks that want to share, and again, we got several manufacturers on the line as well. But the seed evaluation template forms are best. It was one of the pre-questions. If anybody wants to talk about that.
Is anyone using a template or a form? I think we kind of talked about this, or are you just putting how it helps with like their MRADLs, that sort of thing? You're just combining it into your LMNs? No real forms being used, or is someone using some sort of form?
We're not using a form. We just put it in our letters.
Okay. So I want to be respectful of everyone's time. We've got a minute left. Is there other things that anyone has a question on? I think this was a really good networking session. I'd like to have others. I don't know if anyone has burning topics that they'd like to put for the next networking session. I suggest that if you do, you can shoot Rose or myself an email with, hey, how about this? And then we can kind of look around or look at putting together a program or a presentation around it with the right players. I think it's interesting hearing from people in different states, what's working, what's not working. So any final comments? Thank you, Peter, for your insight and your time. We greatly appreciate it. Rose, any final housekeeping things?
No, not at this point. But Peter, again, we can't thank you enough for participating today and especially staying on the line. I think it was very helpful, your questions that you asked. We do have some action items that have come away with this. I know Jennifer had to leave the meeting, but we'll certainly do some follow-up that we discussed on this call. And again, we would like to thank US Rehab for sponsoring Peter. It was wonderful. And
thank you, Greg Packer.
Yes, and please keep us posted. And again, as Julie indicated, Mames is actually made up of 8 regional states in the Midwest. So we have access to a lot of information and a lot of different providers. So, you know, going forward, hopefully we can get you the information that you need to be successful at the federal level.
That's great. Thank you very much for the invitation. I've enjoyed it. And I also learned a lot. And I love that additional information that I think Julie is going to send. So thanks to everyone for the additional information. And we'll keep you informed as to how this goes.
Well, good luck. Again, thanks all. And thank you, Nancy. Appreciate it.
You're welcome. Everybody have a great day.
Bye now.
All righty, bye-bye.
See you, everybody.